Okay, let's jump right into this explainer covering some seriously high-stakes emergency and trauma surgery clinical protocols. Here's what we're looking at today. First, the burst abdomen emergency. Then, lower extremity vascular trauma. We'll follow that up with mapping femoral nerve deficits, tackle traumatic asphyxia syndrome, and wrap up with gastric injuries and drainage.
So, Section 1, the burst abdomen emergency, specifically managing evisceration. Let's get into it.
Here's your first clinical scenario. You've got a patient with a burst abdomen, and those eviscerated contents, they cannot be easily reduced back at the bedside. So what's the appropriate management here? Looking at our options, do we apply immediate continuous sutures, apply tension sutures, hold IV fluids, cover the viscera with a sterile dressing to close later, or pass a Foley catheter? Well, the correct move is absolutely covering the viscera with a sterile dressing. You know, forcing swollen tissue through a facial defect under non-sterile bedside conditions is incredibly dangerous. Getting a sterile dressing on there and immediately transferring the patient to the OR is literally the only correct choice. Once you're in the OR, what are the steps? First, you've got to debride those wound margins. Second, wash the peritoneal cavity with warm saline. Third, close it up with heavy, non-absorbable interrupted mass sutures. And finally, support the whole thing with deep retention sutures. The key takeaway here? We completely abandon continuous suture lines. Using an interrupted mass closure strategy is absolutely crucial to prevent a catastrophic failure of that entire wound line.
Moving on to Section 2, lower extremity vascular trauma, focusing on defending perfusion.
All right, consider this scenario. A patient presents with a gunshot wound to the left thigh. Out of all your clinical findings, which one definitively warrants urgent surgical exploration? This comes down to differentiating your hard signs from your soft signs. Hard signs are an immediate mandate for the OR. We're talking complete absence of palpable distal pulses, an expanding or pulsatile hematoma, or active pulsatile hemorrhage. You see those, you go. Soft signs, on the other hand, mean a CT angiography is indicated first. These include a history of moderate hemorrhage, a diminished distal pulse, or an ABI of less than 0.9. So say you're exploring that gunshot wound to the thigh, and you find a massive 5-centimeter defect in the superficial femoral artery. What is your appropriate management strategy now? This brings us straight to the tension rule. This rule dictates that if an arterial tissue gap exceeds just 1 to 2 centimeters, primary end-to-end suturing is completely contraindicated because of excessive tension. You just can't stretch it. Instead, a venous or prosthetic graft is required. So, what kind of graft do you use? Let's break it down. An autologous vein graft, specifically a reversed saphenous vein, is the gold standard. It has a much lower infection risk, but the obvious downside is that it requires precious time to harvest. On the flip side, a prosthetic graft, like EPTFE or Dacron, has the massive advantage of off-the-shelf availability. It's rapid, but you're trading that speed for a higher long-term thrombosis risk. Okay, let's hit Section 3, mapping femoral nerve deficits and neurological triage.
Let's look at another gunshot patient, this time to the right thigh. They're showing weakness when trying to extend the knee, they've got a diminished knee-jerk reflex, and there's sensory loss on the anterior and medial thigh. Based on that presentation, which nerve is damaged?
If you said the femoral nerve, specifically L2 through L4, you hit the nail on the head. Let's look at the deficit profile. Motor-wise, you'll see an inability to extend the knee joint against gravity and weak hip flexion. For sensory, expect anesthesia encompassing the anterior and medial thigh, running all the way down to the medial malleolus. And for reflexes, you're looking at a complete loss, or at least a severe dampening, of the deep tendon patellar reflex.
Moving right along to Section 4, the traumatic asphyxia syndrome and crush dynamics.
Here's your question for this section. What specific mechanism of injury is directly linked to the development of traumatic asphyxia?
It all comes down to a severe, sudden crush injury to the chest. That's the trigger. This intense compression literally forces a massive volume of blood to shoot backward from the right atrium straight into the valveless superior vena cava. Because there are no valves to stop it, this retrograde flow causes deep facial cyanosis, severe edema, and ruptured capillary beds all across the neck and chest.
And finally, Section 5, gastric injuries and drainage, looking at the abdominal washout.
Imagine this. Weeks after a trauma laparotomy, a follow-up CT scan shows fluid accumulating in the subhepatic space. Which injured organ is the most likely source of that fluid?
The likely source is a delayed leak from the stomach, liver, or duodenum. Why? It's all about gravity.
Morrison's pouch, or the hepatorenal recess, is the most dependent drainage space in a supine patient. That makes it the primary pooling zone for any delayed leaks from those specific organs.
Let's test this with one more question. Which of the following statements related to gastric injury is not true?
Okay, let's look at some gastric trauma pearls. The false statement is the idea that blood in the stomach is always related to a primary gastric injury. Actually, scratch that assumption. In truth, patients very often swallow massive volumes of blood from proximal facial or tracheobronchial trauma. In terms of etiology, over 95% of true gastric injuries come from penetrating trauma. And for the repair, it absolutely requires a secure two-layer closure. But the good news is it heals exceptionally well.
I love this quote. The essence of trauma surgery is the delicate balance between rapid bedside triage and definitive operative restoration. It really is a high-stakes balancing act.
So, I'll leave you with this thought. Will your bedside decisions hold up when the pressure is truly on? When that hematoma is expanding right in front of you and literally every single second counts?